Thank you very much, Mr. Chairman. I have a brief presentation which will outline what is being proposed today before the board. The proposal is how we take the next steps toward offering supervised injection services in Toronto. Now, supervised injection, of course, is a form of harm reduction. Harm reduction is measures that reduce the harms associated with substance use, not only for individual users, but also for their families and the communities. And it is one of the 4 pillars of the Toronto drug strategy, the others being enforcement, treatment, and prevention. Now, you as a Board of Health already oversee the delivery of a number of harm reduction services by Toronto Public Health. Those include the distribution of sterile needles and other safer drug use supplies. And this happens at our own program, the Works, as well as through nearly 50 agencies which deliver these supplies to 80 sites around the city. We supply the needles and training and facilitate the availability of these services. We also do overdose prevention through the distribution of naloxone, a medication which acts as an antidote for opiate overdose. We conduct offer testing for infectious diseases which are transmitted by injection drug use. We offer vaccination. We offer methadone, a form of opioid substitution treatment, and of course referral to a wide range of other services which can benefit injection drug users. So this is the existing landscape in terms of harm reduction services offered by Toronto Public Health. Supervised injection, which is one more harm reduction service, are health services that provide a safer and more hygienic environment where people can inject their own pre-obtained drugs under the supervision of a nurse. In 2013, I reported to the board on the evidence for the effectiveness of supervised injection service as an intervention. And there is a wide range of studies that have been made internationally, including peer-reviewed research, which demonstrate that supervised injection reduces deaths due to overdose. And it's not hard to see why. When someone is taking their drugs in a supervised environment where there's a medical professional available to assist, it's much less likely that they'll die of overdose. It tends to reduce the behaviors that transmit infectious diseases like HIV and hepatitis. It's been shown to increase referral to detox and drug treatment services. And it also has a number of community benefits, including reducing public drug use. When someone is injecting indoors in a supervised facility, they're not injecting in an alleyway or a stairwell. It reduces publicly discarded needles. Again, when the drug user leaves the supervised injection service, they leave the needle behind. They've also been found to be cost-effective in terms of as an alternative to the health costs associated with injection drug use, and have not been found to increase criminal activity in the areas surrounding where the service is operated. So the primary service offered at a supervised injection service site is a hygienic place to inject. There's also, of course, the provision of sterile supplies, safer drug use, education, and medical or nursing supervision of the injection process. Many of the services which are offered in conjunction with SIS are similar to the services which are already offered in Toronto, including by Toronto Public Health. Supervised injection is not new. It's been operating for more than 30 years, and there are currently about 90 such services operating around the world, mostly in Europe, Australia, and here in Canada, with 2 sites operating in Vancouver. More are being planned. The most advanced next to Vancouver is Montreal, who are already well into the development of their program. These programs were originally implemented to address both health issues for the users as well as public safety, including reducing public drug use and the discarding of used needles. There are 3 different models which you see if you look around the world. One is a standalone service, and Insight in Vancouver is the Canadian example of that. There are integrated services, which are part of organizations which offer a range of other health services, and there are, in some places, mobile services. We have some history of dealing with this issue in Toronto. The drug strategy, the Toronto drug strategy, which was adopted by City Council in 2005 with the 4 pillars that I mentioned, called for a needs assessment and feasibility study to see whether supervised injection services were the right way to go for the City of Toronto. That study was ultimately done and published in 2012 as the Toronto and Ottawa Supervised Consumption Assessment, TOSCA study, and it made a number of recommendations. It recommended that Toronto would indeed benefit from having multiple supervised injection services integrated into existing health service organizations serving people who inject drugs. The idea of a model of multiple sites really was the best fit from the point of view of the feasibility study because of the nature and distribution of drug use in the City of Toronto. It also said these programs should be evaluated once they were implemented. The Board of Health supported the implementation of this form of integrated model of supervised injection service in 2013. As we look at the landscape today, there is ample evidence of the need for supervised injection here in Toronto. Over the 10-year period, 2004 to 2013, there have been a 41% increase in overdose deaths in this city, largely as a result of a rise in opioid deaths, deaths from that category of drugs which includes heroin and fentanyl. This information was presented to the board last September in a report on prevention of overdoses in the City of Toronto. I've just very recently received updated information from the Ontario coroner, which allows us to look at the trend in overdose deaths continuing to 2014. And the total number of deaths in 2014 is 252. So it's gone up another about 20% compared to 2013. So the concern about increases in overdose deaths, I think, has continued. We see a high demand for existing harm reduction services across the city. There were over 100,000 client visits to the services which are supported by Toronto Public Health, and almost 1.9 million sterile needles were distributed, again in 2015. The clients of those services exhibit the risks that supervised injection is intended to address, and that is a high proportion are hepatitis C positive, an important proportion are HIV positive, and many experience overdose. This is a graph from the September 2015 report, which shows the trend of increase in total overdose deaths. Now, this includes overdoses of all types. You can see that there's a significant upward trend. If you add the 2014 data of 252 deaths in total, that represents about a 73% increase over the period since 2004. This next graph breaks down by the most frequently used type of drug, and you can see the black line represents opioid-related deaths. They clearly are the biggest proportion both of the burden of illness and also of the upward trend that we've seen over the past decade. The report before you describes the fact that there are 3 health service agencies in the city, including Toronto Public Health, who are planning to add a small-scale supervised injection service to their existing health services for people who inject drugs. The 3 agencies are Toronto Public Health at our site in Victoria and Dundas called The Works, the Queen West Central Toronto Community Health Centre at Richmond and Bathurst, and the South Riverdale Community Health Centre at Queen and Carlaw. These agencies, although they are moving forward each one to develop these programs and services, are closely coordinating program and policy development so that there will be a coherent citywide approach to these services. So why these 3 locations? Each one is in a community which experiences high rates of injection drug use and associated risk behaviors, including frequent injection, overdose and the risks associated with it, and public injection. Taken together, these 3 sites distribute about 3/4 of the sterile needles which are distributed across the city. So they are already serving the majority of the population who use harm reduction services. All 3 organizations have been in the business of delivering harm reduction services to injection drug users for a long time, and they have the demonstrated capacity and skill to deliver this type of services to people who inject drugs. We have local indicators of need, which are outlined in the report, that talk about the number of client visits and needles distributed at each of the 3 sites. Each has a significant client group which would benefit from supervised injection. About 1/3 of the clients who visit these services report injecting in public, in stairwells, in public washrooms, and other places. About 1/3 of them say that they have had an overdose, obviously not a fatal overdose, in the previous 6 months. And they say when asked that they want and would use a supervised injection service. The model which is being considered by all 3 agencies is an integrated service model in which the supervised injection service is added to existing programs within existing program space. There would be no change to the exterior of the premises, and you wouldn't know by going by the facility that there was an additional service that was being offered. The benefits of having an integrated service is that clients will have access to a continuum of health and harm reduction services tailored to their needs. Now, we know from a wide range of evidence, including the feasibility study done here in Toronto, that drug users will not travel very far to use a service like supervised injection, and that has some important implications. One is that you need multiple sites in order to reach a dispersed population of users, and that's the proposal which is before you. It also means that most of the users of this service are going to be individuals who are already clients of these three agencies. It also means that if you set up a supervised injection service, it will not attract people from across the city because users just will not travel that far in order to be able to inject. There is an example of the type of model that is being proposed in Canada, and it's not in sight in the downtown east side. It is the Dr. Peters Centre in a very nice neighborhood in Vancouver. This is an organization which offers a range of both day and residential services for people who are drug users or otherwise have HIV. Here's a picture of it. It's a pretty nice neighborhood. If you go inside to the room where supervised injection takes place, it looks like this. There are three sort of cubicles equipped with sterile supplies. And if you can just see in the mirror, there is a nursing station immediately opposite where the supervision takes place. This center has been operating very quietly for many, many years without conflict with the local neighborhood. How will these services actually work? Well, clients will arrive with their drugs, which they've obtained themselves. There will be inside waiting rooms, so people won't be lined up on the street. They'll be assessed for program eligibility and then brought into the supervised injection room where they'll be given sterile supplies and supervised during the injection process. They then move into another room called the chill-out room, typically in this type of facility, for observation of any negative drug reactions which may occur. It also gives them an opportunity to interact with the program professional staff and identify whether referral to any other services are appropriate. Now, supervised injection is legal in Canada, but it does require an exemption from the Federal Controlled Drugs and Substances Act. There is legislation that outlines the criteria which must be included in an application for this exemption, which includes quite a lot of supporting data, detailed plans about how the facility will operate and how the services will be provided. There needs to be financial information, indications of how these services will be linked to other services for drug users, and the views of a number of key community stakeholders, like the Minister of Health, the local municipality, and the police chief, need to be included, along with any strategies to address any concerns that those stakeholders may raise. Another requirement is the results of a significant community consultation, and it is that direction for the community consultation that we're seeking from the board today. The consultation is a very important part of implementation. The three agencies will each need to consult with their local communities, but the process will be closely coordinated. The plan is to retain an external group to facilitate public meetings, online surveys, site visits, in order to seek out, to educate and inform the local community about these services, why they're important and how they will be delivered, and also to seek out any concerns or questions from the local community. It's also expected that this process will help identify some local community members who could be part of an ongoing advisory group to help manage the relationship between the agency offering the services and the local communities. My recommendation suggests that we can complete this recommendation and bring back its results to the Board of Health at the July meeting for this year. Now, we have to recognize that supervised injection services are only one part of a spectrum of services to respond to the health harms and the community impacts of injection drug use. They will not eliminate all harmful drug use, or for that matter, all overdoses, but I think they are a key part of the range of solutions which are needed in the City of Toronto. And overall, with supervised injection, we will expect to see improved health outcomes for injection drug users and reduced community impacts of injection drug use. Thank you, Mr. Chairman. That's the end of my remarks, and I'll be happy to answer any questions at the appropriate time.
Great, thank you very much, Dr. McKeown, and I think the appropriate time is going to be after the deputations. So first, we have our deputations. The list is now closed. I'm going to ask you if you are the next speaker.